All right. So as you all noticed, first of all, happy Sunday. As you've all noticed, there are a couple of very large sort of beast kind of topics with the fellowship review. This is probably one of them because we're going to basically talk about sick patients from cradle to hopefully not grave. There's a lot of information in here, so I'm going to kind of try to highlight some things so that you're not buried in things. I promise I'm not going to show much histology. I'm going to just a little bit, and I just want to walk you through how to work through sick patients. So the first thing I got to do is make my disclaimer that these are my views and nobody else pays me but the DoD. All right, this is what we're going to talk about today. We're going to start with basically sick patients. What kinds of things will get your patients into trouble in terms of medical emergencies, how you manage those things. Then that'll be about a third of what we're going to do. Then we're going to talk about some clinical oral pathology and oral medicine, oral cancer type stuff. And we'll talk about some of the things like HPV, and then we'll hit radiographic pathology and bone pathology, and we'll try to build on what Dr. Mahmood was talking about. I know we had a chance to have some good discussions, and you had good questions on Friday. So we'll try to build on some of those things. So first thing you got to start is knowing your patients. All right. So, a lot of these things are memorization kind of tools, but I think the take home point here is that your ASA class 1 and class 2 patients, those are your healthy patients or patients with systemic disease that don't really impact their ability to function during a day, can be treated as an outpatient type thing. Once you have individuals who are ASA class 3, who have significant health problems, these are patients you need to think about either medical consultation or engaging these patients in a hospital type environment. So that's the purpose of this kind of slide, and I just pulled these out of the ASA classification. The other sort of sticky wicket that we have is the Cardiology and Heart Association sort of changed our guidances. So what used to be stage 1 hypertension is now stage 2 hypertension, which is your patients who have blood pressures 140/90 or higher. And what used to be your pre-hypertension is now stage 1 hypertension. So when you're looking at any kind of patient or any kind of question or any kind of course, you have to look very carefully at those systolic and those diastolic numbers. And you also have to be aware that your patients who hit the 180/120 mark are going to have a typically hypertensive crisis. And by definition, they should have some medical intervention before you do anything else on them. And we're going to roll this into some discussions about hypertension and a cardiovascular disease. And we'll start here with your stage 1 and stage 2 hypertensions. And it's our first jumping point off to say, okay, who do you treat, who don't you treat? So generally your stage 1 hypertensives, right? Those are the individuals who have less than 140/90. They can tolerate most procedures well. You might do some stress reductive techniques. It's your stage 2 hypertensives that you have to take a second thought and go, okay, maybe I need a consultation with the physician. Maybe I need to delay my elective procedures. And those are the folks we'll talk about limiting your vasoconstrictor, at least as a rule set out of the textbooks. And for your patients who have a hypertensive crisis where they're hitting 180/120, you really should be referring those, especially if they're symptomatic, to a physician. So when it comes to your hypertensives and your patients with cardiovascular risk, we talk about limiting epinephrine and we talk about limiting lidocaine. And so we're going to do a little bit of math here, not to hurt your heads, but to get you thinking about things. So for healthy patients, generally speaking, the epinephrine dose is going to be limited to about 11 to 12 carpules. Malamed and most of the health community will talk about the textbook answer for your cardiovascular disease, and those are the folks that you limit their epinephrine to 2.35 carpules. And we sort of wag this down to 2 carpules. Bear in mind, though, that your patients will produce about 300 times more epinephrine every minute that they're uncomfortable. So the textbook answer might be 2 carpules, but the reality answer is you can give your patients additional local anesthetic and vasoconstrictor if you're separating it out and you're pacing it out and you're monitoring your patients. So that's the first thing. The second thing is if you follow the lidocaine guidelines, and we've switched now to the 1.7 mil cartridge things. I know this thought between 1.8 and 1.7, but if you follow the guidances out of Malamed, your limb fac, as we call it in the military, your limiting factor would be 8 to 9 cartridges. So if you follow the lidocaine guidances, you'll never max out on your epinephrine in your healthy patients. So that's something to bear in mind. We're going to come back to this as well because you'll hear about patients and articles talk about, oh, patients can't have lidocaine because they're allergic to local anesthetic. The reality is it's the bisulfite preservatives that the patients are allergic to. We're going to come back and visit that again as an important point, right? So lidocaine limits you to about 8.8 carpules. Epinephrine in a healthy patient would get you to about 11 or 12, and in your cardiovascular patients, it's about 2. But you need to be aware of the fact there's going to be some sensitive populations. So this is your first potential emergency waiting to happen in your dental offices. And those are individuals who are substance abusers or individuals who are on specific subsets of medications, particularly those that they're going through some of these cytochrome systems. So they'll compete for the local anesthetics, and so those anesthetics will hang around for a lot longer. So you have to think about the type of patients you're going to encounter, right? So we think about our typical meth abusers or your cocaine abusers that have all the poor oral hygiene, and they tend to present in agitated type states, and they may be showing signs of withdrawal and the sweating and all that kind of stuff. So there'll be a lot of medication drug interactions, and you'll need to work through those things, right? Because we all know what happens if you have an epinephrine overdose, right? The patients get tachycardic, they get hypertensive. The lidocaine overdoses are a little bit different because they'll get excited first, they'll get stimulated, then they will crash. So it's stimulatory followed by depression. And so they're initially their heart rates and blood pressures and so forth will be elevated, and then they'll depress, and then they can actually go into cardiovascular collapse. And you may have to do things like oxygen treatment, anticonvulsants, and obviously 911. So bear that in mind. So your way you manage these overdoses is by aspirating and not injecting lidocaine into the vasculature, and then by managing those excitatory states while they're still excitatory before your patients crash. All right. So when you stay on the drug train, in terms of lidocaine, epinephrine, the next major group of potential emergencies are going to be those patients who have infections. So we're going to talk about infections, managing them, and what kind of medications to do. So when I look at things like infections, when I look at asthma, when I look at angina pectoris, when I look at cardiovascular disease, I just try to peg them into the stable / non-emergent versus unstable / emergent. So when you have emergent type infections, it's usually locational. So these are your canine space things that go into cavernous sinus, things back in the airway, parapharyngeal, Ludwig's angina, and then anything that extends into the actual other spaces. So you'll have to be watching out for your patients who have eye closures, significant swellings underneath the mandible, the so-called bull necks, right? And then based on that, you have to choose antibiotics. Short of doing sensitivities and cultures, you have to choose antibiotics that are, what we like is the narrowest broad spectrum antibiotic possible. Now, in spite of all the antibiotic resistance we're having, penicillins in general, and we're going to talk about this in the context of what kind of bacteria you encounter in the oral cavity, are going to be the drug of choice, right? Now, we may switch to amoxicillins to get them to a 2 or 3 times a day regimen. We understand for patient compliance and convenience, it's good. But remember, amoxicillins can be a little bit broader spectrum, but we want the narrowest broad spectrum. So penicillin 4 times a day, amoxicillin 500 3 times a day, amoxicillin 875 twice per day. They're all going to be equally sort of effective. If they're allergic to amoxicillin, then they usually go to some kind of macrolide. Now, the macrolides, like clindamycin, they get bad raps because there's a higher rate of pseudomembranous colitis with those. Depending on which articles you look at, most textbooks will tell you clindamycin is the bad actor, but it turns out erythromycin can be pretty potent as well. So you'll have to be aware of that if your patients are on things like clindamycin for a while. We have discussions about metronidazole and vancomycin. They are not first-line therapies, right? So they'll be good for those pseudomembranous colitis cases or those resistant cases or some periodontal pathogen cases, but in order, it should be penicillins first, then things like clindamycin, and then for some of your periodontal issues or for your C. difficile type things, vancomycin. C. difficile is not to be taken lightly. That's what killed my mom. So it's not something to be taken lightly. Okay, the reason that we choose penicillins is based on our bacterial profile. So I just pulled these out of the journal article in Advanced Dental Sciences. If you look, most oral cavity bacteria are going to be gram-positive aerobes, or they're going to be gram-negative periodontal pathogens. And as it turns out, penicillins will cover most of those things. But when you get to some of the Bacteroides and spirochetes, that's when you start bringing in things like metronidazole. So if you think about it, most things are. There's one exception to that, and that's the actinomycetes. So you'll hear about actinomycosis. Those are gram-positive anaerobes. Those are the ones that show up on the skin as the smelly sulfur granule kind of infections. And we're going to come back to those again a little bit towards the end. All right, so if you compare oral versus skin versus mouth, nose versus mouth and everything else, you're gonna see common themes show up. So on skin, we deal with staph infections, which can impact us if we're in and around the mouth. Generally speaking, in the nose and the mouth, you're gonna get somewhere between staph and streptococcal species. So just knowing that the oral floras tend to be sort of the gram-positives, and then the gingival type stuff tends to be more kind of gram-negative type things, then you can choose your antibiotics appropriately. The one infection that you want to try to avoid is an infective endocarditis, right? And so I think we need to have a discussion about this because these individuals don't get treated the way they used to, right? We used to think about everybody get antibiotics. There's only 4 things you need to know about for infective endocarditis, and that's going to be folks who have a prosthetic valve, somebody who's had endocarditis in the past, somebody who has an unrepaired or recently repaired cyanotic defect, or somebody who's had a heart transplant if there's a valvulopathy. All the other stuff, mitral valve prolapse, mitral valve prolapse with regurgitation, some of the cardiomyopathies, those are not indications for prophylaxis anymore. So it's only these 4 things that you need to premedicate for. But if you're going to do it, it's anything where you're going to manipulate gingival tissue or cause bleeding, right? So if you're just going to bond brackets, you don't need premedication. If you're just going to do local anesthetic injection into healthy tissue, you don't need premedication. But if you're going to incise, if you're going to place cord, if you're going to sink an implant, if you're going to take out a tooth, you'll need to premedicate your individuals, okay? Your drugs generally fall into either penicillins or clindamycins. A couple of points about this is that the doses can be given 30 to 60 minutes prior to procedure. And in those emergent cases where the patient comes in, there's an emergent issue, you have to get the tooth out, the guidances allow you to actually rescue with 2 grams up to 2 hours after the procedure. And that has to do with how long the bacteremia stands around. So adults, 2 grams or 600 milligrams of clindamycin, and then the kids is going to be 50 or 20 milligrams per kilogram. If they can't take oral medications, then you just switch to ampicillin, same kind of dose as amoxicillin, or you can switch to clindamycin if they're truly allergic. And I would encourage you to avoid cephalosporins if they're a penicillin allergic because of similarities in chemistry, right? And it is 30 to 60 minutes prior or up to 2 hours rescue. And if you got to do repeated procedures, what they recommend is wash the patients out for 7 to 10 days if you can, or if you got to bring it back immediately, then switch antibiotic classes. So if you've just done amoxicillin this week, you need them back next week, you might want to switch to clindamycin. Okay. All right, so that's all your pharmacologic type stuff. As it turns out, the most common emergency you're going to have in your office is going to be syncope, right? Now, there's really common causes for this, all right? Patients are low on oxygen, low on blood pressure, low on heart rate, and I probably would add a 4th, and that's hypoglycemia. So the way you manage those things is very easy. You give them oxygen, you give them fluids, you give them stimulants, or you give them sugar if they're perfectly conscious and so forth. You don't give anybody, Coca-Cola if they're halfway out the door, because then they'll be choking. So again, positioning is good. So we talk about Trendelenburg to get blood back to the upper portions of the body. We're going to talk about drugs. We're going to very briefly mention BLS and ACLS protocols. And obviously for all these patients who may be at risk, monitoring, right? If you have patients who are not doing so great, maybe they're a high ASA class 2, consider having pulse oximetry and blood pressure monitors and maybe even ECGs, EKGs if you're going to do some advanced dental care. Drugs to have in your armamentarium would include oxygen. Now, there's one caveat to oxygen. For your patients who have chronic obstructive pulmonary diseases, you have to turn their oxygen down because those individuals, if you give too much oxygen, you will reduce their capacity to breathe. It's actually a reverse stimulation. You certainly can wake them up with ammonia inhalants and cold compresses as an adjunct. For your patients who are hypertensive, the best thing to do is give them fluids. So again, having some IV skill starts in your office will be helpful. And then things like phenylephrine and epinephrine are basically going to be stimulators, and they're going to basically cause vasoconstriction, which will up your blood pressure. But be careful in your patients who are already cardiac stressed. And then for patients who have slow heart rates that are symptomatic, oxygen's always a good thing, and then atropine, because it does the reverse. It actually will stimulate your heart to beat faster. So those are the things to consider, all right? And then the numbers and the dosages are there for you for your thought processes. What you want to avoid is this. You want to avoid angina pectoris, which basically just means just pain in the chest, right? And it could be anything, including a pulled muscle. But in your patients who are cardiac issues, this is my thought process behind stable and unstable. So your patients who may have actually had, say, a bypass, 6 months or a year ago, and now they're running like 5Ks, and like, yeah, at the end of the 5K, I get a little chest pain, I pop a nitroglycerin, I'm fine. They're stable. You can probably monitor them in your office and do what you got to do. But your patients who are waking up in the middle of the night because they've got chest pain, and they can't walk up a flight of stairs, those are the unstable individuals, and those are the individuals you may want to consider avoiding elective care. And then for the patients who are going to have nitroglycerin, they need to bring it with them. And then it's every 5 minutes up to 15 minutes. And if they're still not responding, that's an MI waiting to happen, or you treat it like an MI. So when you get to those individuals, early morning's usually better because they're going to be in better shape. And if they have chest pain, you stop what you're doing. Oxygen, okay, high flow for anybody who's not chronic obstructive disease, low flow for people who are. Nitroglycerin, you start giving them that. And then we talk about limiting the vasoconstrictor again, with the understanding that the patients are going to produce a lot more epinephrine. So keeping your patients comfortable with stress reduction, IV sedation, things like that is known, it's helpful, and there's plenty of studies to support it. If you have a patient who does actually have an MI, now these guidelines are changing a little bit. We don't necessarily promote morphine dosing as much anymore, and maybe or maybe not anticoagulations, but I want you to know about Mona because she's your friend. So morphine for pain or some other pain management, oxygen to keep the cardiac and the brain systems going, nitroglycerin to dilate the blood vessels, decrease the workload on the heart, and then specifically your patients who we know are having MIs, especially when they get to the ERs, they will get anticoagulants. So if you have aspirin and they're a known cardiac patient, it's actually okay. You should be trained on how to administer the aspirins and know what the side effects are. And you definitely need to know about CPR basics. Now, depending on whose train you follow, if you're following American Heart, now it's CAB, right? It's circulation, airway, and breathing. If you follow the American Red Cross, it's airway, breathing, circulation. In the midst of coronavirus, you have to check, especially if you're working in a hospital-based system. Our hospital-based system right now is hands-only CPR, unless you're part of the actual crash team that actually has the appropriate PPE. So you need to look at that within your facility. But the basics of CPR are the basics of CPR, right? It's head tilts, chin lifts, look, listen, and feel, doing your two breaths, and then if you need to go into your 30s and 2s, you do those things. You should be aware of those things and how to do those things. What we're trying to prevent is MIs and strokes. So let's start with strokes and talk about a few stroke risk facts here. It's all about risk factors. So if you look at your patients who are hypertensive, stage 2 or higher, right, or patients who actually have dysrhythmias, or patients who actually have high cholesterols and high couch potato ratios and high body mass indices, those will be your high risks. There's a few things you need to know about patients who are stroke risks. It turns out that if you have a stroke, your elevated risk is at least one more month, and then about 14% will reoccur. You'll get another stroke within a year. And so we talk about delaying treatment. We're going to make a delineation between stroke and MI. Stroke is a 6-month wait, right? That's what the recommendation is. We'll talk about 6 weeks for MI, but for strokes, it's 6 months, right? So what happens with your patients when you dial 911 and EMS shows up? Now, this is a very busy kind of slide, but I want to walk you through a few things. The first thing to notice is the EMS is going to do the same things you're going to do, right? They're going to do ABCs, CPR with or without defibrillation if they need it. They're going to follow Mona's protocol, but they're going to add a 12-lead ECG, and then they're going to prep them for the type of protocol based on whether or not their baseline in the ECG is elevated or depressed. So if they have an elevation, that's an MI, and they'll treat them accordingly. If they have a depression, that's ischemia, and they'll treat them accordingly. And so based on whether or not they actually have an elevation, they go STEMI, depression, they go ischemia type things, and then if they have a normal EKG, they'll monitor. I've been there because I had bad reflux and I showed up in the ER as a 48-year-old, and so I got the full bore. I got aspirin, and I actually wound up on a treadmill, and it was all fine. I ran 16.5 mets. I'm good. So bear that in mind. So that's what happens when you do ischemia. When it comes to strokes, there's a few other facts you need to know. And I'm going to parse just one or two things out on this slide for you. And the first one is the 60-minute mark. That is door to drug. So if you ever get a question or someone asks you, or you're working with cardiac patients or stroke patients particularly, you need to know that if they're going to land in an ER from the time that they're carted into the ER, they have to go through all the CT and everything else because they need drugs 60 minutes. Admissions and on the floors, 3 hours, right? So door to drug is 60 minutes, door to admit is 3 hours. So you need to bear that in mind, which is why you as the provider need to move pretty quickly and get EMS on board because they need to get, every minute counts, all right? When it comes to MI, what happens is they do a fibrinolytic checklist. So if they think they're having a STEMI, and they don't have any contraindications, right? They don't have brain bleeds, then they'll get fibrinolysis. They'll get clot busters, right? Otherwise, they'll stop and put them into a different protocol. There's a couple of critical time periods here, right? So chest discomfort more than 15 minutes, right? That's your, I've given them 3 nitroglycerins and it's not getting better. Now you treat it like an MI. As long as they're within the 12-hour window, they're primed for a STEMI protocol. So again, so some time periods, right? It's 12 hours for MIs is your window of opportunity. 60 minutes is your window of opportunity for stroke for drugs, and 3 hours is your window of opportunity for admissions and so forth, right? And then obviously these patients, if they're stroke victims, then they'll have all their drugs and monitoring. If they're MI victims, their next stop is probably going to be a cath lab. Right, and we're going to bear that in mind when we get to how you manage these things and how long you wait. So what does the ACC, American College of Cardiologists, say? All right, we talked about strokes, right? 60 minutes, 3 hours. What about the ACC? And we talked about waiting 6 months on patients who have strokes to do elective care. ACC says if they've had appropriate thrombolytic therapy, PTC is percutaneous transcutaneous transcardiac angiography. All right, that means they get a catheter, right? They get cathed. So if they've had thrombolytics and cath and they've been revascularized and they can get on a treadmill and they can do 4 or 5 mets and run up a flight of stairs, you can press with your treatments at 6 months. All right. So again, strokes 6 weeks. Sorry, 6 weeks. 6 weeks. So strokes 6 months. MIs 6 weeks. All right. There's no more 6-month delay for these individuals. But these individuals may be in a group of patients who have coagulation disorders. So when you talk about bleeding problems, they're either going to be inherited or acquired. The inherited stuff, more often than not, the most common reason is von Willebrand disease. That's a platelet problem. Or they're going to have hemophilia, and that's most commonly A, and that's a factor VIII deficiency. These patients will bleed longer. Or they lose all their clotting factors because of liver disease, because that's where your clotting factors are made. Or they're taking a lot of drugs like diuretics and they lose vitamin K, and some of those cofactors disappear, and so they don't coagulate as well. Or in our patients who are on MI stroke protocols, they're therapeutically anticoagulating. That's also include things like ibuprofens and aspirins and things like that. So you need to know what some of the drugs are. So for patients who have platelet related coagulopathies, it's probably due to either aspirin or one of these ADP binders like Plavix or Brilinta. You have to understand that platelets live for about 10 days. So once you've given them the aspirin drug, those platelets are now non-functional for 10 days. So if you've got to do some work on them this week and they've just had a dose of something, you're going to have to potentially deal with bleeding a little bit longer. The ADP receptors, it's a little different, but it's still pretty much the same 10 days type stuff. So I've just given you some of the trade names so you can kind of see what the drugs are. When it comes to the actual coagulation cascade, I promise I'm not going to show you the coagulation cascade. All I'm going to do is talk about extrinsic, intrinsic, and common. So Coumadin is part of the extrinsic. right? That's the vitamin K dependent cofactors, 2, 7, 9, and 10, right? Coumadin is the drug for which you will do INRs. It is the only drug for which you will do INRs. Heparin and Lovenox are intrinsic pathway issues, and then all the other stuff like Atrixa, Pradaxa, and Xarelto, those are common pathways. So INR is not going to help you for Pradaxa. INR is not going to help you for Xarelto, and these patients usually higher risk anyway. So what we do on our patients who do get some kind of measurement is we used to do PTs and PTTs, but again, they vary according to the laboratories. So there's a corrected ratio, and you just need to know what the INR means. And you need to know that the only medication that you're monitoring on an INR is Coumadin. So once again, Coumadin is the only medication that you're monitoring with an INR. Now the question is what INR values do we want for our patients? So large studies basically say your patients double their risk for a cardiovascular or a cardio, stroke type thing when they dive under 2. So what they shoot for is a minimum INR value of 2 in patients who are being treated for stroke, and it's pretty much the same for MI as well. So if you look at the recommendations, and this is out of the chest journals, 2 to 3 is the recommended therapeutic range for most patients that are going to be therapeutically anticoagulated. That's for things like MI, stroke, AFib-related strokes. It's 2 to 3. And we do not have literature to support us discontinuing their medications. Right? It's not our place to do that. That's the physician's decision. And the physician will weigh the risks and the benefits of saying, okay, you sent me a consult saying you're going to take out a lot of teeth or you're going to do a lot of periodontal surgery. It's going to be bloody. I got it. They'll make the decision about whether or not they're going to discontinue. But if they drop them below an INR of 2, now you've doubled their stroke risk, even over the course of a day or two. So you may get a no, we're not going to change it. And then you'll address this through some local measures. So what do we do as dentists? We're like Harry Potter superpower here, right? We have lots of things we can do, right? We can do pressure with our gauzes. We can use good surgical techniques. We can get primary closure. We can use sutures. If you're going to go down the INR road, you may be able to get a physician to drop the INR to somewhere between 1 and 1.5. They're never going to get them down to 1. You'll never get them to do that. So you and I, healthy, 1 is fine, but for these individuals, they're going to be slightly anticoagulated. If they're on Xarelto or Pradaxa or any of these other medications, INR is not going to help. Don't ask for it. Your physicians aren't going to do it. It's only for Coumadin. I repeat that again. Right? There are a couple other things you can actually place into the areas. Now we talk about gel foam all the time. Gel foam has no has no coagulative properties unto itself. It's a scaffold, but if you mix it with thrombin, which just takes you directly to the common part of the cascade, then you're getting them direct to coagulation. And if you think about wound injury, right? Once you expose wounds, you expose collagen, and collagen makes the platelets go crazy. It makes them clump and clot. So that's why using a lot of these collagen products is pretty good because you'll actually promote coagulation. So you mix these things with good suturing, and in most cases, if you're doing minor type surgeries, you can manage these individuals very well. Okay, that's bleeding. All right, we're going to work our way. So we start left. We're leaving the heart. We're leaving the cardiovascular system. We're going to go to the lungs. 3 major diseases or disorders you need to think about with the lungs. And the first is going to be your constrictive type things, which are going to be your asthmatics. You're going to have your inflammatory type things, which are going to be your patients with bronchitis. And then you're going to actually have your alveolar destruction. Now, because people are going to ask me, what about COVID? Okay, COVID has to do with not coagulation, but it actually has to do with condensation of membrane material within the alveoli. So you get these thick sort of membranes that the blood and the oxygen can't pass through, and that's why individuals wind up under positive pressure in the ER. So that's maybe a fourth kind of thing. Treat them the same way you would treat your angina patients, as either stable or unstable. So you think about your stable asthmatics, right? I run a marathon in the middle of Texas in the summer and the mountain cedar's getting to me and I take an inhaler and I'm good. Versus your patient who lands up in the ER like, 3, 4, 5, 6 times a year getting epinephrine doses because they have unstable asthma. So, you treat your stable folks, make them bring their inhalers, if they're unstable, you might want to hold off on doing those things. So have your patients bring your inhalers. Now, your inhalers are going to fall into probably one of 2 or 3 areas. One, they're going to be things like theophylline or other things which tend to be bronchodilators, or they're going to be anti-inflammatories like hydrocortisone, or you can actually go down the road of actually giving them IVs and giving them beta agonists, which basically just dilate their bronchioles. Oxygen's a good thing unless they have COPD, and then they just turn down the volume a little bit, right? Patients who have asthma, there's a triad of aspirin-sensitive allergies, allergic rhinosinusitis, and asthma. And so avoid aspirin and Demerol in those patients. That's important because you can potentially set them off into an asthmatic attack. You have to know under these concerns, sorry that my lines are a little bit messed up here. You have to know that all this stuff blends into allergy and immunology, so you have to know what your types of reactions are. So type 1, right, that's our anaphylactic reactions. Type 2 and type 3 are usually humoral immunity. So those take a little longer to pop up. And then type 4 is usually your contact type stuff, right? So your powder, your gloves, not true latex allergy, just kind of the stuff we put on, the resins and so forth. All right. And then you put that into the context of what we started talking about, which is all the drugs we put into our patients, right? So again, local anesthetics are not the problem. It's probably the actual sulfites as the preservatives. We know that probably at least 10% of the US population is allergic to penicillin. It's up there with bee stings. We know that asthmatics are going to be sensitive to aspirins. We obviously know that some people are latex allergic, so that's why we try to keep latex-free facilities, because that's truly type 1. That's the folks who will get anaphylactic. So, avoid latex rubber dams if you can. Dental materials and topical agents are usually sort of more delayed type 3 type things. So, you just kind of avoid those things. And then there's a subset of patients who are on ACE inhibitors for their blood pressure that can get sort of the angioedema, swollen lip. Okay, and again, local anesthetics themselves are not the problems. It's usually the bisulfite preservative. So what do you do for your emergencies? How do you manage those things? Well, what you do is you keep drugs around. So my wife likes to camp with the Boy Scouts, and so I say, okay, you guys take Benadryl with you, right? So if they're perfectly conscious, Benadryl is a good first line antihistamine, but it will have some sedating effects. Otherwise, you're going to epinephrine, right? And hopefully you can get it for less than $900 a carpule, right? But that's the thing, and you know that you should know that it's 1 to 1,000, and you can give it subcutaneous IM or IV, and you repeat those things. And you should probably be calling emergency if you're going down that road anyway. For your contact dermatitis, your gloves types, things like that, just hydrocortisone creams are probably fine. All right. All right, so that covers drugs, that covers cardiovascular, that covers asthma. I want to talk a little bit about endocrine problems because they can cause emergencies in your practice too, especially for your patients who don't eat but take their meds and bottom out. So one change that hopefully everybody's aware of right now is that in addition to fasting glucose, the magic number is 126, or random glucose, the magic number is 200, and HbA1c, which measures across the life of a
Hello, please stand by. Dr. Kleeman is currently frozen. He is reconnecting and we will resume this presentation shortly. Thank you. Please continue to stand by as we reconnect with Dr. Kleeman. Thank you. We appreciate your patience. Thank you for standing by.
Thank you everyone so much. I just spoke with Dr. Klingman. He's just logging out and logging back in. So don't worry, we've got some built-in time in the presentation. He's hoping it's going to be less than 5 minutes. So thank you again for your patience.
All right, everybody, you got me back?
We can hear you loud and clear.
Excellent, excellent. You'll all be happy to know. You will all be happy to know that I defeated the Dementors and Voldemort, and Harry is safe. It's all in the pineapples, man. Okay, so let's go back to my presentation here, and we will play catch up. All right. So I don't know where I lost you all, so I'm going to back up a little bit, and we're going to go back to allergy and immunology, and hopefully that'll work okay. So what we talked about in context of reactive airway disease is that there's a whole set of allergy and immunology findings, and you have to remember what subset you're actually dealing with. Are you dealing with type 1 hypersensitivities, the so-called anaphylactic reactions? Are you dealing with the dental materials that we put into our patients' mouths that are typically type 2 or type 3? Or do we have like the contact stuff from like our gloves and things like that, which is type 4? So when it comes to that, sorry, I'm having one more burp here. Give me just a second. Close that down. Go back to play. So I'll tell you a quick aside story, and Chris knows this. At one of the AGD live fellowship reviews, our streams were crossed, and so a gentleman in the next room was actually advancing my slides for me, and I was advancing his slides for him. And so we managed, and it was fine. So we'll recover. Okay, so when it comes to allergy immunology, when you talk about the things that go into our patients that we give them, remember, it's not the anesthetics themselves that are problems. It's probably the bisulfate preservatives. Obviously, penicillins, that's going to be a type 1 or anaphylactic reaction. Aspirin are the folks you have to watch for your asthmatics. Most of the materials, other than latex, are going to be delayed type hypersensitivities. Sorry, going to take a drink. And then our topical agents are going to be typically contact type stuff. And there's a subset of patients who are on blood pressure medications who get the so-called angioedema. So your drugs will be things like oral antihistamines like diphenhydramine, or if your patients are severe, they're going to be things like epinephrine. And then your topical steroids are good for your topical type things. Okay, diabetes is, so endocrine disorders can be your next problem in terms of emergencies. When it comes to diabetes, again, and if I repeated this again and you heard me, we're going to say it one more time anyway. They bottom out if you have them take their medication and you don't have them eat. And then diagnosis is a little bit different because it used to be fasting at 126, random at 200. Now the HbA1c, which is your life of the blood cell kind of things, right? So that's every 4 months, 120 days. If they have an HbA1c over 6.4, those folks are considered to be diabetic. It's important because if you're going to keep your patient's NPO for whatever reason, right? You're going to do IV sedations, or you're going to do a lot of surgery, and your patients are not going to be able to eat, then you may have to alter their medication regimens, because if you don't, they're going to bottom out on you, and you may actually have a hypoglycemic emergency. So when in all doubt, if you can just have your patients eat. If you need to have them NPO, your long-acting agents like metformin will need to probably be discontinued. And fortunately, most of the patients now are wearing, like, little injectable devices that sort of monitor their insulin. But if they do still physically inject themselves with short-acting insulins, you might have to do that. If they're on any of the medications in the box on the right, those individuals are going to be high-risk patients. That's what that's all about. So all these new hormone analogs, they're going to be higher risk diabetic patients, which means they're going to be probably be less controlled, which means you might need to consider antibiotics for these patients if you're doing surgical procedures, because their wound healing is going to be decreased. So things you can do if you're going to have them NPO, have them turn down their medication dosages, get with their endocrinologist to tell them what you're doing. Obviously, have them bring whatever monitoring devices, or you should have a monitoring device. Do finger sticks to see where they're at when you're in the chair. And then obviously, if they're immune suppressed because they're poorly controlled, you might have to consider antibiotics. All right, you're going to take out some teeth, you're going to sink implants, you're probably going to have to do some antibiotics with those individuals. And talk to your physicians. One of the sequelae of both hypertension and diabetes is end-stage renal disease, right? Because your kidney's the filter for filtering out all the fluids and everything else. So a couple things you need to avoid are drugs that can send you over into renal failure. So non-steroidals and some antibiotics. Remember, your kidney produces erythropoietin, so patients who have chronic kidney disease might be anemic. Patients who are actually on dialysis will have coagulation issues because they're going to be on heparin. And then there's debate about patients who have dialysis and transplants, because things like the shunts, they may get infected if you actually do procedures on them. So you may want to engage with the urology folks to see if they need to have antibiotic prophylaxis, just like we do for infective endocarditis. And then obviously, if they have a transplant and they're immune suppressed, you're probably going to have to use antibiotics for a lot of your procedures. Your liver is the other organ that you have to be aware of, because you can get hepatitis and/or cirrhosis from a variety of reasons. Most of us think about viral hepatitis or alcohol and drug, but we're finding out now, said the guy who's 50 years old and who has a little bit of a fatty liver, there's some non-alcoholic fatty liver diseases you need to be aware of. So when it comes to the viruses, I can't do better than the CDC. So remember, A and E are dietary. That's foodborne hepatitis. B, C, and D is the sort of the bloodborne type and the sexually transmitted hepatitis. There's a vaccine for A and a vaccine for B. If you're immune to B, you're immune to D. It's the C that's the problem, because there's no vaccine, there's no real good test for it. The good news is now there's 2 or 3 drug combinations that have very high, over 95% cure rates. But what you need to be aware of is, I found this out when I turned 50, is if you have fatty liver and it goes unchecked, you can get non-alcoholic liver disease, and you can get cirrhosis that way. So I'm in that age range now where they're going to keep an eye on me just to make sure that I don't lose my liver function. All right, because if they have end-stage liver disease, then you're going to have problems processing drugs, and as a result, your drugs may hang around a lot longer, or they may have untoward effects. They're going to have clotting issues for obvious reasons because of all their clotting factors. And then obviously patients who get liver, hepatomegaly oftentimes tend to get splenomegaly and their spleens get big and then they sequester platelets, and that's another problem. And if they have a transplant, sorry, welcome to Texas where I have allergies. I promise it's not coronavirus. At least I hope it isn't. You might have to prophylax with antibiotics. All right. The other virus that I think we need to throw into here, it's a very different disease now than it was when I went to dental school, when I had to walk uphill in the snow both ways, and I was thankful. Um, uh, Patients who have HIV disease are not necessarily sick, right? As long as they're taking their medications and they have that's a so-called HART or highly active antiretroviral therapy, then they can tolerate dental care, and you can't turn them away. They're protected under Americans with Disabilities Act. But if they have sequelae diseases, like respiratory diseases and immune suppression and cancer, and it's beyond your capability to take care of it in your office, as long as you can find them a referral place to go and have their dental care, that's okay. You could say, I'm just not capable of doing that here. All right, but just bear in mind, they're going to have a lot of associated diseases. I'm not going to go into them because it would take us all day. They don't necessarily have to have antibiotic prophylaxis. It's not the CD4 count that's really as important, it's the neutrophil count. And so if they're dropping below that about 1,000, then they're going to be prone to infections. All right. I want to talk just a little bit about gastrointestinal disease because we're going to transition into things like, bone pathologies and giant cell lesions. So there's three major organ systems you need to sort of maintain a lot of your metabolic control. One is your gut, because that's where all the, metabolic beautiful things come into your body, all the food. Your kidney, which is going to help you absorb things like vitamin D and a lot of your other vitamins. And then we're going to produce vitamin D to help you absorb things like calcium. And then your parathyroid and other endocrine glands that are going to maintain this stuff. So patients who have GI disease, things like long-term antibiotic use, Crohn's disease, pernicious anemia where they don't produce intrinsic factor, they're going to have a harder time absorbing all the nutrients they do. So I've listed the B, C, D, and K deficiencies, what the actual oral findings would be in those cases. They typically present with oral soreness, ulcerative diseases, gingivitis. We're going to talk about calcium stuff when we get to giant cell granulomas. And then obviously vitamin K, because they'll be coagulopathic. So we're going to come back to the GI system, the kidney, and the parathyroids when we get to bone tumors, because this is what happens and how your body actually maintains everything, right? Your osteoclasts, which are actually the giant cells and the giant cell tumors, their job is to pull calcium out, right? To get it back into your blood when you're low on calcium for whatever reason. They pull it out of the bones. The parathyroid is the gland that produces the hormone that regulates it, and the kidneys is what produces the vitamin D that helps you absorb the calcium in the first place. All right, so we're going to come back to that. When it comes to pregnancy, what you basically need to know is that with the exception of articaine, bupivacaine, and mepivacaine, almost every single drug that we give our patients is class B. It's okay to use in pregnancy. Just connect with your obstetrician. First trimester is the most crucial, and that's where the one you're going to want to avoid as much as you possibly can, because that's when the brain and everything else is forming. So just remember that when you're looking at drugs, you just need to know what the pregnancy category is. All right, we're finally up to my area of stuff. So, hey, I'm doing pretty good. I'm only probably about like 15 minutes behind where I want to be, but we're gonna play catch up because the dementias are all gone. All right, white lesions, leukoplakias, red lesions, erythroplakias. Right? I see a lot of folks write white lesion and say hyperkeratosis. It's okay, but really it's leukoplakia and erythroplakia. So when you're talking about biopsy with your patients, because they panic when I say biopsy, just remember biopsy is just looking at human tissues, right? Could be urine, it could be blood. But what you guys are familiar with is incisional, excisional, and maybe brush. So incisional, worried, take a small piece of tissue looking for diagnosis. Excisional, fibroma, cut it out. All right, and then brush things. The issue with brush tests and a lot of these other tests we're going to talk about is they have high false positive rates, so they'll have lower specificity. So if you want to do brush tests, it's okay, but you may not get the answer you want. Radiology is really, to me, a biopsy, a diagnostic method. So again, to sort of piggyback on what Dr. Mahmood said the other day, right? So plain radiography and CT or cone beam CT, that's ionizing radiation. Good for osseous morphology, maybe a little soft tissue. MRI, no ionizing radiation, has that nice T1 and T2, right? The fat and the fluid images, but no radiation, good for soft tissue. And then PET scan is just an introductory to the folks who deal with any patients who have cancer. It's radioactive glucose, and it goes to areas of metabolic activity. And so that's going to be places where there's inflammation or malignancy. Helps us when we're staging cancers to find out how big the lymph nodes are. When you talk about all the products like Visilite, Microlux, and Velscope, and I'm not advocating for any of these, and I'm not advocating against, you just need to understand how they work. So Visilite and Microlux is reflected light, and Velscope is autofluorescence, and those also have lower specificities, right? High false positive rates. So you might get a result that might be abnormal when it's really just a melanotic macule. All right, when you then dive into pathologies themselves, I'm a big fan of the rule of threes, whether or not you're like Steve Jobs or anybody else. So if you can put soft tissue nodules into reactive, neoplastic, or developmental, your list is here for you to figure these things out. So a lot of the stuff you come across is going to really be reactive. Things like neurofibromas and schwannomas are truly tumors, and some of them will have syndromes, and we'll get to those. And then there's all the developmental things like tori and some of the developmental cysts, which are basically locational. So again, deciding fibroma versus pyogenic granuloma is really just a matter of how bloody it is. So, they're going to present in similar fashions. Now, everybody thinks pyogenic granulomas, but that's only the gingiva. No, it's anywhere you have trauma, right? So these become histologic diagnoses, right? Here's your 3 Ps laid out for you as examples, right? There's a common thread to all 3 of these things. Number 1, you should get vitality testing on all the teeth that are involved, just to prove it's not a parulus. Number 2, you should get a periapical radiograph or small field cone beam CT to evaluate your periapex, and you should do some periodontal probing in these cases. I'm sorry, the mountain cedar or something is around here again. Because sometimes this is the answer, right? So, doing vitality testing or doing radiography and even putting a gutta-percha tracer in here may help solve the problem. So there's your 4th P right there, right? When it comes to salivary things, that's not my fingers, that's the patient's fingers. It was one of my histology techs, and he bit his lip and he got a mucocele. The floor of the mouth mucoceles just get a fancy name, a ranula. That's all. It's just a fancy name. Instead of vanilla, it's French vanilla. Okay. When it comes to these developmental cysts, sorry, I'm gonna take another drink. When it comes to developmental cysts, if they're limited to just the gingiva, they're gingival cysts. If they're in the bone, we're gonna see they're called lateral periodontal cysts. All the tonsillar tissues and the lymph nodes in the floor of your mouth can have these developmental cysts called lymphoepithelial cysts. So think Waldeyer's ring. And then floor of mouth cysts, again, to piggyback on what Dr. Mahmood said, if you have capability to capture occlusal films, great. If you don't, then use your slob rule, right? Capture an image, then capture an image at a different horizontal angulation if you can. And then if your cone moves to the mesial and the lesion moves to the mesial and it's stone, then you know it's on the lingual. Same lingual, opposite buccal. So your summaries are pyogenic granulomas are usually red and bleed. Peripheral ossifying fibromas have bone in the center, so they're hard. Peripheral giant cell granulomas may be a component of central giant cell granulomas, and then you have to go down the kidney parathyroid road. When it comes to actual tumors, right? Now this is where it gets sticky because the textbooks will tell you that in the tongue, the granular cell tumor is the most common soft tissue neoplasm. I could debate that because fibroma may be the true answer, but the textbooks will tell you granular cell tumor. More importantly, it's good to know that neuromas and neurofibromas, sorry, give me a second, I'm gonna pop a mint in my mouth. And I promise you won't hear it shuffling around. When it comes to neuromas and neurofibromas, you're gonna have potentially syndromes associated with those. So neuromas go with MEN, and neurofibromas easily enough go with neurofibromatosis, and we'll come back to those. When I talked about developmental cysts, it's all about, whether there's lymphoid tissue, in which case you have all these lymphoepithelial cysts. And because they tend to be yellow, you can add other things like yellow lesions like lipomas and granular cell tumors and some nerve tumors into this mix as well. When it comes to developmental cysts, it's all about location, right? So if they're up in the midline, you think nasopalatine duct cysts. If they're in the globula maxillary, so like over here by the lateral incisor, they're called nasoalveolar cysts. Most of them turn out to be OKCs. We'll get there. If they're gingiva, you want to make sure it's not in the bone. And then the floor of the mouth stuff is you want to just make sure there's not a hard tissue mass down there. All right, when it comes to salivary gland tumors, once we move out of mucoceles, just again, apply the same rules. They're either going to be benign or malignant, and try to memorize lists. Names change. But if you remember that pleomorphic adenomas or mixed tumors are the most common benign salivary gland tumors, and mucoepidermoid carcinomas are the most common malignant salivary gland tumors, you're going to solve 90% of your diagnostic dilemmas, and you're going to know, okay, somebody has to biopsy these things. Everything else is just a list for me to figure out, because all this stuff is histologic stuff. So, right, so just remember it's benign or malignant, and those are your most commons. What you also need to know is that the vast majority of salivary gland tumors land in the parotid glands, as many as 80% of them, with almost all the rest of them showing up in the minor glands. So like, roof of the mouth, buccal mucosal, lip. Of the tumors, the vast majority of parotid tumors are going to be benign. So I'm showing you malignancy frequencies. Everything else is 50-50, which is why you biopsy them. It's only the sublingual gland that's worrisome. Most of those tend to be malignant. So when you do some generalizations to help you even just respond to your patients, lower lip stuff, traumatize them, it's a mucocele until proven otherwise. Upper lip, it's going to be one of these benign tumors. And then just remember, pleomorphic adenomas or benign mixed tumors are the most common benign salivary gland tumors, and mucoeps are the most common malignant salivary gland tumors. And I just kind of came up with this 80-50-20 rule because I'm kind of like a dumb truck driver. Not that I'm suggesting that truck drivers are any more or less intelligent than anybody else. I'm just a dumb guy, right? I did say it at Holiday Inn Express once, and I'm not promoting that company. All right, but 80% of parotid tumors are benign, 50% of submandibular and minor tumors are benign, and 20% of sublinguals are benign. So that's my 80-50-20 rule. All right, guess what? Same rules apply to mucosal and epithelial pathology. And this way you can move through these things fairly quickly. So I got leukoplakias and keratoses. They're either going to be frictional stuff or they're going to be pre-malignancies or malignancies. Ulcerations are either going to be traumatic, inflammatory, infectious, or cancers. And all these immune inflammatory type things are either going to be lichen planus, pemphigus. We're going to talk about erythema multiforme, or they're going to be cancer, right? Because that's what it's all about for the mucosal pathology. So the first thing to do is figure out if these things are worrisome or not. So when you get bilateral lesions, it's usually not cancer. So then you need to just rule out tobacco use. After that, you play stretchy man with your patients. So if it doesn't go away, it's white sponge nevus. And this will run in families. If it goes away when you stretch it, it's leukoedema. All right. And these are just abnormal keratin production. Usually don't need biopsies, don't need any follow-up. If you know that your patients are parafunctional people, then you'll understand why they have the white line. Textbook, they love to give it that fancy name, morsicatio. It just means friction or chewing. If it's on the cheek, it's buccurum. Tongue is lingularum. Lip is labiorum. I just call it white line or cheek biting. All right. So again, not cancer. And even red lesions in high-risk sites. Both sides, not cancer. Migratory glossitis. Choose your name. I like erythema migrans only because it means red stuff that moves around. All right. But when it's a unilateral ulcer, you're going to have to find a cause, especially when it's a high-risk site. So the folks at The Ohio State University, we all share cases with each other. So this is an example of somebody who actually traumatized their tongue. And again, 2 weeks, 3 weeks, you can monitor these things and see if it resolves. If there's a broken cusp nearby, fix it and see what happens. Best selfie I ever took, this is me. So other than traumatic ulcers, this is probably the most common kind of ulcer you're going to come across, which is the typical aphthous ulcer. Your patients call them canker sores, right? We all have bad days. I was getting ready to take a board exam, so I had an aphthous ulcer, right? So that's your kind of ulcerations. All right, let's get into lichen planus, pemphigus, and pemphigoid. All right, the trick for lichen planus is look for striations like you have here. Right now, you're going to see some pigmentation here. Anytime you have inflammation, you can get pigmentation. It's just a normal thing that comes along with it. So lichen planus, look for striations. This was the same patient who also had a desquamative gingivitis. So when you get desquamative gingivitis, hint, hint, your differential diagnosis is lichen planus and pemphigus and pemphigoid. So let's look at a pemphigus case to show you the difference, right? These are the folks that have spontaneous ulcerations. They have desquamation of a lot of different sites, and they also tend to actually have a higher rate of Nikolsky sign. All of these folks can have Nikolsky sign, by the way. And then finally, pemphigoid, well, the ones that have the little blister, so you can see the blister between the lateral and the central incisor. These are the folks you need to be looking at the eyes and the nose. All these patients, you should be looking at the skin on the face and the arms. This is a different story. This was a 16-year-old patient I saw actually he was admitted to the hospital. All right, he had an ear infection, got antibiotics. It was a penicillin. He wound up with eventually his lips crusted, and then he had the target lesion. So this is erythema multiforme. These patients are usually younger, and they usually get this because of some sort of medication or something like a viral exposure. And so when it comes to ulcer disorders, again, just try to peg them into a category. So more often than not, they're going to be traumatic. If they fall into this inflammatory category, I want to point your attention to the fact that aphthostomatitis and lichenoid mucositis are both thought to be T-cell chronic inflammatory disorders. And so we treat both of those with topical steroids. Erythema migrans might have an association with psoriasis. When you biopsy them, if you do, and you don't usually have to, they'll look like psoriasis to me under the microscope. And then erythema multiforme has usually got the history to go along with it, right? A medication, and then all of a sudden they got the ulcerations and the target lesions. Pemphigus, pemphigoid, and lupus are truly autoimmune disorders, and those are ones you're gonna have to investigate more deeply, right? Pemphigus will have the spontaneous ulcerations, pemphigoid will have the blisters, and lupus will have things like the butterfly rash, renal problems, other immune problems, and so forth. All right. So when it comes to lichen planus, bottom line, look for striations, and then also look and see if there's a dental material, a mouthwash, a dentifrice, or something else like that, because those will actually contribute to those. When it comes to pemphigoid, you're looking for bully or blisters, and you have to look at the eyes, and you have to make referrals for those patients, because if not, their eyes can scar down and they can lose their vision. For pemphigus, those are folks who have the typical more ragged ulcerations. They have a higher rate of Nikolsky sign, and they will oftentimes have systemic diseases, and so you'll need to refer those to primary care for a workup. And then also, I mentioned vitamin C deficiency. Those folks can get actually a desquamative gingivitis as well. So when it comes to generalized gingival overgrowth as opposed to ulcerations, you have to think about not only hygiene-related stuff, but medications, right? We're going to talk about cyclosporin, dilantin, and calcium channel blockers. That's the one that everybody spits out like a Pavlovian response, and that's fair. But you need to think about patients like this. This patient I saw, she was a nice lady. She had leukemia. She got scaling root planing. This is what happened 2 days later. So she got biopsied, and this is leukemic infiltrate. So cancers can show up as gingival enlargements. And so when you get gingival overgrowths, other than hygiene issues and necrotizing gingival diseases with the punched out papillae, we're not going to go into the classification. Dr. Morse took care of that one the other day. All right, you have to consider medications, and there's your list. You have to consider malignancies. There are some hereditary disorders. Usually they have developmental delay. And then there's a whole bunch of these granulomatous or reactive diseases. So things like some of those fungal infections, those actinomycosis, the ones with the sulfur granules, GI diseases like Crohn's, and then obviously in the lips, foreign bodies for things like lip augmentation materials. And I've seen cases where patients, they get like cement from crowns, it causes a foreign body reaction, so that can cause some gingival overgrowth as well. When it comes to pigmentary disorders, it's either physiologic, benign melanocytic type things, which is either like melanin production. I know the filter on the left is a little red, but when it's small like that, it's probably benign. The one on the right was worrisome because it was irregular. We're not going to discuss the titanium deficiency where the bicuspid is, right? So these were both oral melanotic macules, but the one on the right got biopsied because of the concern for the irregularities. You don't want this to happen. So this is a melanoma. So this is what you're trying to rule out. So when it comes to that, try to find a history. There's an easy one here, right? This is a tattoo. And I say this to my patients all the time, dude, you got a tat, right? So you can find a history for this. That's helpful. Medications can also cause pigmentary disorders. So they're usually quinines, which are used for both malaria and for lupus treatment, and then things like antipsychotics and some antibiotics. And here's an example of the antibiotic. Now, I'm going to make a disclaimer on this one. This photograph was actually taken at Lackland. It got shared in a study exchange. This photo is actually in the Neville and Dam textbook, so I do need to make that disclaimer. It made it to the textbook. And you can see the blue bone kind of under the bluish color of the bone underneath, and then you can see the banding. So when it comes to oral pigmentation, physiologic, right? Some systemic things, right? So we're going to talk a little bit about syndromes as we go, and I'm going to try to go faster and catch up. We have time, right? Addison's disease, think John F. Kennedy, right? So they get pigmentation, and the issue there is not the kidneys, it's the adrenal glands, if anybody asks you, right? And then Peutz-Jeghers, those are the ones that get the freckling around the mouth. They get polyps in the GI system, but they're not malignant. We're going to compare that to Gardner's syndrome with the osteomas, which do have malignant polyps. Melanotic macules, that's just melanin pigmentation. Nevi or moles, to quote Austin Powers, moly, moly, mole, right? That's melanin and melanocytes, or they're truly malignant like melanomas. There's a short list of medications. Broad categories include quinines, tetracyclines, and some psychiatric medications. And then vascular lesions can cause pigmentation too. And the trick to figuring out hemangioma versus hematoma is just try to blanch them. So if they blanch, they're probably vascular. If they don't, they're probably hematomas. And then if they have the little petechiae, the little ones, you do have to go back to those hematologic things, including the coagulopathies. I've put your melanoma ABCDEs here for you. So it's all about asymmetry, borders, color variation, size, and then change over time. And then when you get to infectious diseases, guess what? We're going to follow the same rule set for these, right? So they're either fungal and bacterial diseases. Those will typically show up in the mouth as some variation of an ulcer. Even all the chancres, the gummas, and the condylomas that are in the syphilis, they're either ulcers, granulomatous ulcers, or papilloma-like lesions. The herpes viruses and the enteroviruses like Coxsackie virus can cause oral ulcerations, and usually those are the ones that start with a blister. They will oftentimes affect the gingiva as well as the oral mucosa, and there's oftentimes fever and malaise. And then just for completeness sake, because we're going to talk about HPV, those are the ones that cause the papillomas and the condylomas. So history helps, right? Asthmatic patient. So we're back to asthmatic patients here, right? Oral inhaled steroids. Patient has the stuff rubs off, leaves the red base, pseudomembranous candidiasis. This is the other situation where you're going to run into candidiasis, your patients who don't take out their dentures. So management for these patients is either a inhaler change if you can do it, or you might have to do a little bit of like a Miselex troche to try to alleviate this. For these patients, it's all about hygiene education, and you have to treat the patient and the denture. So to use that fancy prosthodontic term you learned probably from Dr. Renda, you have to put the antifungal on the intaglio surface of the prosthesis, all right? When it comes to viral disorders, this is the typical presentation. This patient was actually pregnant. So you can see there's vesicles and ulcers on the tongue, there's gingival erythema, and then on the palate, there's coalescing vesicles and ulcers that actually ride up to the gingival margins, which does not happen in aphthous. And this patient also had fever. This patient, by the way, got treated with antivirals to protect her and her baby. This is the recurrence, right? So recurrences, unlike this is primary, it's bilateral. Recurrences will be unilateral, or they'll show up on the lip, or they'll show up on the fingers like a Whitlow, or they'll show up as a zoster, all right? And they're usually unilateral along one or more dermatomes. And the patients will also have potentially oral ulcers and pain, all right? So you just need to know the difference between primary and recurrence. All right, to finish it off, benign HPV causes papillomas, right? This is an excise or just watch. So when it comes to viral lesions, again, here's your 8 herpes viruses. As it turns out, any of the first 4 or 5 can cause oral ulcers. 6 and 7 is usually skin rashes in kids. 8's the one with Kaposi sarcoma. And then hand, foot, and mouth disease, herpes angina, all that stuff, that's all enteroviruses. And it's really based on seasonal type stuff, and then the patients may also have like hand and foot kind of things, and you may want to ask them, can I look at your hands and feet? What it's really about is driving ourselves to figure out if there's a cancer. All right, so here's your stats for cancers as of last year. The numbers will probably ride a little bit higher. Now the oral cancers also includes tonsils, so that's your numbers. Here's where the leukoplakias and the erythroplakias need your attention, because 25% of your leukoplakia, if you can't otherwise explain it, right? I'm not talking about your, your leukoedemas. I'm not talking about your, frictional keratoses. I'm talking about there's a keratosis or a white lesion you can't explain. So 25% of those can be dysplasias. The red lesions, almost 90% of them can be dysplasias or cancers. That's why you have to watch those things. You have to know where to look. So as it turns, I said this is kind of like when I was in high school. I was the nerd that used to like to ride in the front of the bus while the rowdy kids in the back would throw spitballs in the back of my head. So these are the spitball throwers. It's posterior oral cavity, oropharynx, and floor of mouth. That's your high risk sites. Your factors traditionally have been things like tobacco, alcohols, and beetle products. But for skin cancers, we think about radiation, right? In order: basal cell carcinomas, squamous cell carcinomas, melanomas. Patients who are immune suppressed, either for HIV, organ transplant, older individuals who have less functioning immune systems, or a number of viral agents and infectious agents like HPV, and we're going to get there. It's important to know a little bit about staging, right? T, how big is the tumor? N, are there lymph nodes? And M, is there metastases? What you need to know is as soon as you have a lymph node involvement, those individuals have stage 3 cancer, and what you need to know then is that your survival rates drop below 50%. That's your take-home message for prognosis. All right, what about HPV-related cancer, right? In a nutshell, your typical smoker and drinker, that's a 65-year-old male. These are 45 to 50-year-old antibodies. They're usually associated with sexual activity, with multiple partners from a young age, and they're usually high-risk HPVs, and they're usually base of tongue oropharynx where you can't necessarily see them. So the histories you'll get will be like, yeah, I've got a lump in my throat, doc, or I'm having trouble swallowing, or they show up with lymph nodes in their neck, and they have higher stage cancers, but they react better and they're better survival rates. So that's what you basically need to know about HPV-related cancers. All right, finally, the last group of things we need to talk about, we are moving along, are bone pathology. So we're going to overlap a little bit with some of what Dr. Mahmood said. So if you can put your bone pathologies, the things you see on your radiographs, into one of these 5 categories, you've probably solved 50% of your questions right then and there. So we're going to look at each of these in some term. We'll start with the fibroosseous lesions. Fibroosseous lesions, to simplify, is all about pulp vitality, whether or not there's pain or expansion, and whether or not they're attached to the roots or not. So the traditional demographic will be middle-aged Black females. That's just by nature of the studies, right? 30 to 50-year-old females. When I was in New York, it was Asian populations. Here in San Antonio, it's Hispanic population, Latino, right? That's just the demographic. So vital teeth, this is early periapical cemento-osseous dysplasia. A different patient that shows up with a later lesion is going to look like this, right? Teeth are vital, not attached to the tooth. For the most part, it looks like it's distinct from the roots. That's periapical. It's when they get to the posterior, they get a little more squirrely. We're going to leave the endodontic problem on tooth number 30 alone for a minute, and we're going to look at 28 and 29. So this is where either periapical radiographs or cone beam CTs will help you, because you can see on the cross-sectional image on the right, this lesion is kind of distinct from the root. And that's how this got more of a cemento-osseous dysplasia, but we considered cementoblastomas. If you also notice, the patients also had previous eye trauma because there's a mesh below the patient's right eyeball. All right, these are the easier ones, right? These are the florid cemento-osseous dysplasias. You really should vitality test the teeth involved, particularly the ones with the crowns. But once you get past that, it's pretty easy to determine that this is probably a florid cemento-osseous dysplasia. Look at the area of number 17. There's even one in the mandible there. All right, when we get to the diffuse stuff, so again, here's that phrase, fibrous dysplasia ground glass again. When you get diffuse lesions like this that show up in a periapical radiograph, this is when panos and cone beam CTs or medical multi-detector CTs are good ideas. So this is what ground glass looks like on a pano on the left, and on the CT, this is what so-called ground glass looks like on a CT, or it would look like on a cone beam CT. And this is monostatic one bone fibrous dysplasia. But if you have a fibrous dysplasia diagnosis, your next syndrome pops up, and it's called McCune-Albright. And those are the folks that have endocrine disorders. So if you get a ground glass fibrous dysplasia case, you've got to investigate it for endocrine disorders. The other end of the spectrum are the very discrete things like dense bone islands. So again, between tooth numbers 20 and 21. I always get the question, can I do orthodontics with patients with dense bone islands and fibroosseous lesions? Yes, you may move a little slower. Can I put implants in? We don't know. There's no evidence for or against, but the success rates may not be as high for those. So you should approach those with caution. All right, so when you get to fibroosseous lesions, here's your list, right? There's all kinds of flavors of cemento-osseous dysplasias. The ossifying fibromas are going to be the ones that are going to be truly expansile. And how they come out surgically differs. We'll talk about that in a minute. Osteoblastomas and cementoblastomas, those are the ones that seem to want to attach to the root. Fibrous dysplasias, ground glass, Paget's disease, cotton wool, and dense bone islands or idiopathic osteosclerosis, very discrete lesions. So what you should do for all these cases is vitality test the teeth, and then it's a combination of symptomatology or lack thereof, and then also what's the surgical situation like. So cemento-osseous dysplasias, that's the gritty hemorrhagic ones that are described in most studies. The gender and ethnicity may not be as important as you think. When it comes to ossifying fibromas, those are the individuals, sorry, I'm gonna take another drink. Those are the individuals will oftentimes have displacement of teeth, expansion, and when those things get removed, they get removed as a solid mass. And it's usually the consistency of an uncooked potato, gritty, solid. When it comes to these lesions, these are the squirrely attached to the tooth, not attached to the tooth. That's where your periapical radiographs, PDLs, cone beam CTs come in. And then they will oftentimes have some expansion and pain. A subset may respond to non-steroidals, and more often than not, they get diagnoses of so-called osteoid osteoma. When it comes to diffuse things, again, it's all about the radiographic pattern. So ground glass, fibrous dysplasia, cotton wool Paget's disease. These patients may have symptomatology because as they get craniofacial fibrous dysplasias, you know, if this hits the sphenoid bone, all the foramen that carry your nerves come out of that bone, or a lot of them do. And so you can get neurologic problems. All right. What about odontogenic stuff, right? Now, we talked a little bit about this, and Dr. Mahmood covered some of this stuff. Now I'm going to show you the pictorial versions of what he covered. So we're going to start with the most common odontogenic cyst, which is going to be a periapical cyst, period. Overall, periapical inflammatory cysts are the most common, right? The history tells the story here, no question. Histologically, it's usually just granulation, tissue, and inflamed cyst lining. Sorry. We're having a pollen day here, I think. When it comes to impacted teeth, these are developmental cysts, and then the answer becomes dentigerous cysts. So periapical first, dentigerous next. And these usually have simple cyst linings. When I mention gingival cysts, if that's the outie belly button, lateral periodontal cysts are the innie belly buttons. But because this thing can be anything else, these usually demand biopsies. You should test the teeth for vitality. They were vital in this case, at least when they started. And these tend to have simple cyst linings. But don't be fooled, because OKCs like to show up anywhere. That globulomaxillary cyst we mentioned earlier, that's one location. This lateral periodontal position, that's the other location. So, I told you I was going to show you a little bit of histology, right? This is the basal palisading, the 5 to 8 cell layers, and the parakeratin. This is OKC. And it was OKC, then it was KCOT. We're back to OKC. The World Health Organization changed their mind again, right? So it's OKC. And we'll talk about the syndrome that goes with that in a minute. They can also mimic dentigerous cysts. So this is where a cone beam CT and a panoramic reconstruction is helpful, right? The question was asked, I think on Friday, it's like, you know, is a pano reconstruction better? Yes, they are more sensitive for sure. So you can see what you get in the cross-sectional images in images 5 to 9, you see expansion and some thinning of the cortex. And that tells you it's a little more aggressive than a dentigerous cyst, and surprise, surprise, you get an OKC diagnosis. All right. When it comes to the most common odontogenic tumors, this was an 11-year-old actually that we saw. So you can see he's got a pano that's kind of cut off, right? So we've got some panoramic issues here. So the patient was probably too far, too far forward or too far back, right? Because he's small. And then you can see in the axial CT on the bottom left, and the sagittal CT, you can see how expansile it is. It's multilocular, it's soap bubbly. And then he's got the basal palisading, and he's got the reverse polarity and the stellate reticulum, right? Open up your Neville and Dams or whatever textbooks you like, and you'll find that in there. All right, so when it comes to these, most of these are going to be inflammatory cysts. If they're developmental, they're most likely going to be dentigerous. As it turns out, OKCs are probably next on the list. When it comes to tumors, it's a medulloblastoma. Now, there's an area of contention in some of the textbooks because they'll talk about odontomas as the most common tumors. I would encourage you to exclude odontomas as tumors and look for a medulloblastoma when you're developing your differential diagnoses. The myeloblastic fibromas and the AOTs, right? Those are the lesion of twos, the kids, failure of eruption, right? 2/3, especially AOTs, 2/3 female, 2/3 anterior, 2/3 maxilla, 2/3 in the first 2 decades. OKC is the twist, right? Because those individuals can have Gorlin syndrome, which is what NBCCS is, right? And those folks have to be evaluated for basal cell carcinoma. So there's your next syndrome there, right? When it comes to non-adenogenic tumors, oh, now we're back to the giant cell granuloma. We're full circle back to those thoughts I had about, you know, giant cells and osteoclasts and calcium metabolism, right? So not, I know in the PDFs and in my PowerPoint, sometimes the images get a little flooded out, but multilocular radialicity crossing the midline. We're going to ignore the impacted canine in the pano here, but this was a central giant cell granuloma. So in the context of kids, when they have bilateral lesions, it's cherubism. These kids will have endocrine disorders, just like these folks who are adults can have parathyroid related central giant cell granulomas, the so-called brown tumors. So when it comes to giant cell lesions, you have to be on the lookout for cherubism in kids, and then the primary and secondary hyperparathyroidism in adults. There are some vascular lesions like aneurysmal bone cysts that will have giant cells in them. And then there are all kinds of these so-called hemorrhagic or vascular lesions that I encourage the surgeons to stick needles in first because you get these, you know, these simple bone cysts or traumatic bone cysts. Those should be empty cavities. The vascular stuff will usually be either low flow or high flow. And if a surgeon sticks a needle in a high flow lesion, the needle's going to fill up pretty quick. So you just need to be aware of these. So I know folks like macho. Just remember that all these lesions can be in any of these locations. We do need to mention some malignancies. So in the patients who are over 50, right, punched out lesions would be myelomas. Now, some textbooks will list myeloma as the most common bone malignancy. Other texts will exclude myelomas and will list osteosarcomas as the most common bone malignancy. So you just be aware of that. You know, when you're developing your differentials, you have to decide whether or not myeloma is in the mix or not. And what is the deal with osteosarcomas, right? That's the one with the supracrestal bone, the weird PDL widening, the numb chin, and then the so-called starburst, which only happens in about 25% of the cases. You should never exclude malignancies in your endos that don't succeed. So this was a lymphoma by diagnosis. And then this in younger kids, the punched out lesions or the destructive lesions, we had one more thing other than giant cell lesions. This would be Langerhans cell histiocytosis. Now I could spend all day on this because they've changed the terminology here. So I encourage you to look up LCH if you're interested in it, because now there's multi-organ and single organ diseases. So an adult with a myeloma diagnosis gets a full workup for myeloma. A kid with a Langerhans cell histiocytosis diagnosis gets a full workup for endocrine diseases and severe diseases. And obviously a subset of these kids will die before they're age 2. So when it comes to non-adenogenic stuff, depends whether you want to think about myeloma as a bone malignancy. Otherwise, the answer is going to be, in most cases, osteosarcomas. Ewing sarcomas happen in kids, and then the punched out lesions in adults are going to be myelomas. In kids, they're going to be Langerhans. All right, and then I've given you some of the thought process behind the sunburst. Okay, hang in there. We are close to done, believe it or not. So Dr. Mahmood kind of gave you his acronym for bone. I learned it as a BLT with a cold kosher pickle, la. Okay, so what you need to know about metastatic diseases is that breast and prostate are the ones that oftentimes affect the bones. And we're going to mention that because we're going to talk about bisphosphonates in just a minute. So those are the ones that are special. But I want to make one diversion to just talk about non-odontogenic cysts first, because I want to show you the most common, right? Why is it they look like hearts? It's because of the anterior nasal spine, right? What about locations below the alveolar canal? They're more often than not staph knee defects. There's usually salivary glands living in here. So locations, this is easy, but I've seen OKCs here, right? Remember we mentioned on Friday that the fine line between a hyperplastic follicle and a dentigerous cyst. Well, there's not necessarily as much of a line between an OKC and a nasopalatine duct cyst, because OKCs can live anywhere. So if you don't know for sure, biopsy it, remove it. Let me tell you what it is. So when it comes to non-odontogenic cyst tumors, nasopalatine duct cysts are going to be the most common on your cyst things. All the other areas like nasoalveolar, nasolabial, they can be anything, which is why we don't like the term globulomaxillary anymore. And then staph knee defects is usually a pretty easy tell on your panos. All right, last group of bone disorders before we talk about just a few syndromes and close it out. Hopefully I'm only about like 10 minutes behind where I want to be. So we're still good. We're going to have time for some Q&A and some breaks. All right, what about diffuse bone diseases? So there's three things you need to be on lookout for. Number one is, are they immune suppressed? Because then you're thinking about osteomyelitis. Do they have a case of radiation therapy, like in this case, in which case you have osteoradionecrosis, or ORN, or have they been on a drug, in which case now I believe this week it's MRONJ, right? It might change again. So what about osteoradionecrosis? I think I'd be remiss if I didn't just hit the high points of you have to know how high a dose the patient gets. So it's usually about 6,000. You have to know what the role of hyperbaric oxygen is, because remember, these are the patients that are hypovascular, hypocellular, hypoxic. And then everybody seems to follow the Marks protocol. So the basic protocol is 20 pre-op and 10 post-op dives. And there's a magic time. If you have to do your surgeries before radiation, it's minimum 3 weeks. That is the recommendation from Mark. It's not 2 weeks, it's not 1 week, it's not 6 months, it's 3 weeks, okay? But when the patient's on a bisphosphonate, like this is a patient, she had breast cancer. So she was on Zometa, which is an IV bisphosphonate. These patients will have medication-related osteonecrosis, right? And under the microscope, it's dead bone and bacterial debris. You have to know that oral bisphosphonates in general have a lower risk than IV bisphosphonates. And usually the IVs are used to treat more severe diseases, right? Severe metabolic bone diseases, metastatic cancers, things like that. All right, so IV bisphosphonates higher risk. There's 3 criteria to make the osteonecrosis diagnosis. They have to have been on a drug. Typically it's bisphosphonate, but it could be a monoclonal antibody like denosumab. They have to have an 8-week run, and there can't be any radiation therapy, right? Now there's a staging system that goes with this. It's stage 0 through 3. We're going to talk about stage 2 and 3 are the only ones where you need to treat them. Stage 0s and 1s that just have a little bit of exposed bone, where no exposed bone, need no treatment. But the risk is important to know, because the IV forms have a higher risk, as do the denosumab is sort of intermediate between the IV and the orals. The IVs and the orals, bisphosphonates, will stay in your bone for about 10 years. The osteoclast inhibitors will live in there for about a week or 2. So it's not quite as severe. And there's some chemotherapy agents that actually will be associated with this. And then there's some mitigating factors like age and other malignancies and immune suppression that will up your risk factors. So if you look at the numbers from the 2014 oral surgery update, and these numbers keep rising. So if I showed you something new from last month, it'd probably be at higher numbers. Really low rates for oral bisphosphonates for osteonecrosis. The IVs, I've seen numbers as high as 25% now, so much higher. And then the things like denosumab are about 2%. So what is the recommendation? Because that's what it's all about. So there's really no recommendation to discontinue the bisphosphonate. In fact, you can't. You'd have to do it for 10 years. And then they get hip fractures, and then they die from the hip fractures. So don't delay your routine dental treatment. There's no evidence to say you actually have to give antibiotics, but the healthier you keep the patients, the better. All right, CTX and other screening tests and treatment, right? In most cases, not required. right? There's no evidence. CTX is a great test for hip fracture risk, but it is not predictive of osteonecrosis, right? If you look at the large studies, and if you look at the Cochrane database, it's not reliable or accurate. So the recommendation is don't do CTX to figure out if they have MRONJ. Now, I got to throw in hips because I mentioned it. So when it comes to total joint replacements, the evidence does not support antibiotic prophylaxis in a dental setting, but the recommendation is to engage with the osteopath. Most osteopaths will want the pre-medication because they don't want to run the risk of taking out the hip. So that one is best to defer. If the physician gives you a written note that says, please pre-medicate them, then you can write the prescription or they can write their prescription. Drugs are the same as for, they're the same as for infective endocarditis. The only difference is it's only 1 hour prior. There's no 30 minutes and there's no 2 hour post rescues. So it's 2 grams of amoxicillin 1 hour prior. And actually the dose is the same for Keflex and Velocif. All right. The last thing I want to talk about is just a couple of dental abnormalities, and then in 5 minutes we're done. And then we can take some questions and go from there. So again, I recovered, you know. We'll break the elder wand at the end. All right. So the difference between amelogenesis imperfecta and dentinogenesis imperfecta is all about whether or not it's a skin problem or a bone problem. So enamel problems will pair with skin problems because these are enamel gene defects. Dentinogenesis or opalescent dentin will pair with osteogenesis. Think Samuel Jackson in Unbreakable and Glass and all those films, right? Those are the ones because that's a collagen problem, right? And then there's some things about teeth being fused, right? So if they're fused at the root, it's called concrescence, and then it's all about tooth count. So if there's a gemination or twinning of a tooth, they're going to have normal number of teeth. They'll just have one tooth looks like it's splitting in two. If they have a fusion, you'll have a decrease in tooth count. That's what it boils down to. All right. All right, here we go. Now we make the final comparison between syndromes, right? So I mentioned Peutz-Jeghers with the freckling and the non-malignant GI polyps. The patients who have odontomas and osteomas will have a potential for Gardner syndrome, and those are the folks that need a GI referral because of GI polyps. The other group of people who have all the supernumerary teeth in particular, not osteomas, will be the folks with the big heads who cannot touch their shoulders together, right? So clinocoidal dysplasias. And then the folks who have congenitally missing teeth are usually components of some kind of ectodermal dysplasia. They're usually males, but I'm going to show you a case of 2 sisters that were twins that actually had ectodermal dysplasias, right? So just what you should be looking for clinically. So think opalescent dentin. This patient came into our clinic looking for some additional cosmetic work. And if you look at this, you'll see there's no pulps on any of these teeth. So this was a dentinogenesis case, as opposed to this case, which looks like all the teeth have been prepped for crowns. They weren't, because the patient's got plenty of pulp, but missing all their enamel. So these patients, you should be on the lookout for osteogenesis. These patients, you should be on the lookout for hair, skin, and nail problems. These patients, you should be asking about GI polyps with, right? So Dr. Reeves is our consultant for radiology, right? So she shared me with this case. Lots of supernumerary teeth. There's a couple osteomas in here. And then you find out this patient has like GI polyps all over the place. And then here's the twins that had the ectodermal dysplasias, congenitally missing 1 or more teeth. All right. So couple thought-provoking questions and then we're done. So this is all about knowing your hypertension stages, right? Knowing that what used to be stage 1 is now stage 2. It's all about the diastolics in the 90s here. Ludwig's angina, it's knowing your spaces, right? So canine goes to the eye and the cavernous sinus. Globulomaxillary goes to the eye and the sinus. Submandibular and sublingual, that's your Ludwig's, and then parapharyngeal is obviously in the neck. All right, this is all about knowing what the 4 criteria are for antibiotic prophylaxis, and it's not mitral valve prolapse, so you don't give anything for these patients. COPD, it's all about turning down the juice, right, in your patients who have COPD, because high flow oxygens will actually turn down their drive to breathe. INRs, it's all about the magic 2 to 3 therapeutic range for your INR. Door to drugs, remember I said For strokes, it's door to drug 1 hour, it's door to admit 3 hours, okay? All right, the reason I put this all of the above softball question is here is because if you're getting kind of a common thought process, when you're making your differential diagnosis, depending on the location, these are the 3 most common soft tissue things you're gonna come across. That's what this question's all about, right? So the problem happens in the tongue because it depends on who you read and who you ask. And that's why I said you have to be careful and, and decide what do you want to consider a fibroma? Is it a reactive lesion or is it a tumor? Otherwise, the textbook says granular cell tumors, right? All right, this is all about knowing which syndrome, right? So neurofibromas go with neurofibromatosis. In this case, neuromas go with MEN. I have 30 questions, by the way, so we're gonna get there. All right, Gardner syndrome, right? Odontomas, osteomas, malignant GI polyps. Eagle syndrome, that's the stylohyoid ligament calcification with the pain turning the head, right? This is all about knowing how your devices work, right? So VisiLight is reflectance, Velscope is the autofluorescence device, Diagnodent is a caries detection device, and Oral CDX is essentially a brush test. All right. Again, oropharyngeal cancer, it's all about HPV now. That's what it boils down to. Common cyst, remember, it's always inflammatory first until you throw on non-odontogenic, then it's nasopalatine duct. When it comes to tumors, I would lean in my literature towards a ameloblastoma. So you just have to be careful about that versus odontomas, right? What about expansile lesions with loss of intervening PDL? This is all about fibroosseous lesions and being attached to the root. So that becomes a cementoblastoma by definition, all right? What about the ground glass, right? We mentioned McCune-Albright, right? Eagle syndrome, styloid ligament, cherubism, giant cell lesions, McCune-Albright, that's the ground glass fibrous dysplasia, and Gardner syndrome is the odontomas and osteomas with the polyps. What about kids with expansile lesions that have central giant cell granulomas? It's cherubism, right? What about opalescent dentin? That's the dentinogenesis imperfecta cases. All right, this is an IV bisphosphonate zometa question, and it's all about the keywords fever and pain. Once you have fever and pain and purulence, now it's stage 3, and it's the stage 3s that you treat. All right, so that's the broad gist behind this question. Compound odontoma, easy. It's the one that looks like a tooth, as opposed to a complex, looks like a mass of nothing, right? All right, local anesthetic question, right? What's the allergen? It's the bisulfite, not the local anesthetic itself, all right? All right, stroke, all right? It's not 30 days, it's 6 months. And then epinephrine dose isn't 2.2 milligrams, it's 0.04 for your cardiac and stroke patients. So that's why it's a double false. Addison's, right? Pigment, yes, but it's not kidney, it's adrenal gland. So the second one is false. Hyperglycemia, right? That's the fruity odor. And again, if you think about it, what does diabetes mellitus mean? It means sweet. It means sweet pea, and I don't mean pea in the little green things, right? They would back in the 1500s they would taste the urine, and if it was sweet, you had a diabetes. So this is the fruity odor, sweet urine kind of thing. All right. What about radiation therapy? I said the magic time is 3 weeks after you do your extractions, not 2. And then what about mandible? It's actually the highest risk. It's not rare, it's very high. So it's a double false. Okay, this is all about somebody gets a dental treatment and now they've got pain and it's up to the gingiva, right? So apathy don't affect the gingiva. Okay, Chris says we need to stop. So I'm stopping. Okay, boom, 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 boom. Sorry. Okay, let me get out of here. Hello. Cancel. All right. Sorry, I was trying to catch up, Chris. All right, over to you.
We have a number of questions, but we are behind now and we need to take a break.
Okay.
So
and I can
why don't we
questions, yeah.
A couple of questions and then we will go on break.
Okay.
Okay. If a patient with a blood pressure 180 over 110, they're in pain and have an abscess, would you prescribe any meds or only refer them back to the ER PCP?
So I think that's a judgment call, right? There's no rule set on that. So I think if they have an abscess and the abscess is the cause of their pain, I think it's, I think at that point in time, I probably would communicate to the ER and say, look, this patient's coming to you with an infection and abscess, and they've got a malignant hypertension. Can you manage both? The answer really is yes. You should treat their infection if you possibly can. So I would probably lean towards a yes, but that's a judgment call. I'm just
Is
walking through.
epinephrine on gauze recommended for bleeding control or tea bags?
All right, so the tea bag issue is there's actually some evidence base behind the tannins in tea as astringents. So that's kind of, we're kind of addressing into the oral surgery kind of thing. There's nothing illegitimate about it. So, there's evidence for it. You can pull up in the Cochrane database for tannins. So the answer is yes, you can use a tea bag or a gauze or both. You use your variety of tools that you have at your disposal.
For Coumadin patients requiring extensive surgery, why do some doctors switch from heparin as slide 36? What makes heparin a better anticoagulant than warfarin?
So the answer is not necessarily a degree of better or worse. It's just the Coumadin's half-life can be up to 2 days. Heparin's half-life is a couple of hours. So the way the regimen works is you draw them off the Coumadin, and as soon as you start drawing them off the Coumadin, you add heparin, and they usually this will be done at sort of an inpatient or a closely monitored patient. You monitor INR. So what you do is you get their INR to as low level as possible. Now, once you've got them off of Coumadin but on heparin, they're still anticoagulated, but then you can do your surgeries because the heparin has a shorter half-life. It allows the patients to clot quicker, and as soon as they form their primary clot and got good coagulation, then what you start is you start drawing them back up on the Coumadin. So that's why they switched from Coumadin to heparin. It has to do with half-life and your ability to get in there in that window and do your surgeries. Great question.
Will sodium bisulfate allergy be related to patients with sulfa drug allergy?
So I think there's a lot of contention about that, and we have this debate with articaine as well. The answer is definitely maybe. All right, so again, it's probably beyond my pharmacology skills to know that, but I think anybody who is sulfur sensitive, you should just avoid sulfur medications altogether. So I've had a couple patients who are sulfur allergic. I would just avoid. You just have to look and see what's in the local anesthetics. You're sort of stuck because a lot of the anesthetics are going to have what they have, and you just have to monitor your patients. Good question, though.
Epinephrine 1 by 10,000 is just for IM, right? 1 by 10,000 is for IV.
So it's 1 to 1,000 is for your emergency rescue medications. That's like your cardiac arrest patients. 1 to 10,000, I've never heard of anybody using it. So typically, if you think about your typical patients, right, it's 1 to 100 or 1 to 50. But I think anything more potent than 1 to 50 should be reserved for emergent situations. So for the most part, the answer to your question is yes, 1 to 1,000 and 1 to 10,000 are probably doses that you're going to find in your crash carts.